Good morning. We continue with the hematopoietic and lymphoid module pathology, lecture 5 and 6. Here in these lectures, we will cover the hemostasis, bleeding disorders, thymus, polycythemia, and white blood cell disorders. We start with hemostasis. Hemostasis, what is the definition of hemostasis? It is a process to prevent and stop bleeding. That's to say, to keep blood within damaged blood vessels. It is just opposite to the hemorrhage and the bleeding. It is the first stage of wound healing that involves coagulation, blood change from the liquid to gel. The intact blood vessels are central to moderating blood's tendency to form clots. So it is the formation of the clot in order to prevent bleeding. This is a hemostasis. Hemostasis depends on the integrity of blood vessels, of the platelet, of coagulation factors, and anticoagulation factors, all of these normally found in the blood and body of the normal human. The endothelial cells of the intact vessels prevent blood clotting with a natural heparin-like molecule, natural anticoagulant that are produced by these endothelial cells, in addition to other materials or other molecules that are produced as thrombomodulin and prevent platelet aggregation by nitric oxide and prostacyclin. When there is injury to the endothelial cell, the endothelial cell stops secretion of coagulation and aggregation inhibitor, and instead it secretes von Willebrand factors. As you remember, in the general pathology, we had this in hemodynamics, and we say that the endothelial cells have two properties, have coagulation properties or procoagulant property in addition to the anticoagulant properties. So when there is injury, the endothelial cell stop secreting the coagulation or the anticoagulant material or the molecules that are normally produced in order to prevent platelet aggregation. While when there is injury, the endothelial cell change its function and stop secretion of coagulation and aggregation inhibitor, and instead it secrete von Willebrand factor, which initiate the maintenance of hemostasis after the injury. Hemostasis has three major steps: vasoconstriction, temporary blockage of a break by platelet plug, and blood coagulation or formation of the fibrin clot. This process seal the hole until the tissue are repaired. The causes of abnormal bleeding. Abnormal bleeding, when there's bleeding, it's either due to the vascular causes or due to the platelet defect, either in the count of the platelet, which is called thrombocytopenia, or in the function of the platelet, or might be due to the defective in the coagulation. Any coagulation factors that included in the intrinsic or extrinsic pathway of coagulation system might be, if there is any defect in these factors, one or more, it would be lead to the abnormal bleeding, or there is dysfunction in the hemostatic function of the body or the state of the blood. The initial laboratory test for bleeding abnormalities. When we have a patient with abnormal bleeding, what is the laboratory test that would be done for those patients? First, we have to know the certain terms that are important as a laboratory investigation that is done and performed in the lab. which is common before surgery, that should be done for the patient in order to know the hemostatic state or the state of the patient regarding the platelet function, regarding the coagulation function. Therefore, these tests should be done for those patients as a preoperative investigation. And at the same time, the laboratory tests are done for the patient that have bleeding tendency, maybe have ecchymosis, maybe have purpura, petechiae, bleeding epistaxis or menorrhagia. Any type of the bleeding that the patient has should be investigated according to the cause that might lead to this bleeding. So first, bleeding time. We have bleeding time. We have prothrombin time. We have partial thromboplastin time, thrombin time. What are these terms referred to? Bleeding time is a medical test done on someone to assess the platelet function and the platelet count. It involves making a patient bleed, then timing how long it takes for them to stop the bleeding. Actually, there is a certain device in the lab, which is a small device. We cut either from the ear or from the skin in the hand, and by filter paper we just touch the site of the bleeding that we induce it, this cutaneous bleeding, cutaneous incision, small incision. We do it by the lancet, and then actually, but not by the lancet, by the device that I told you about. Then by filter paper we just tap on this blood in order to by filter paper till we found we reach the time that there is no more bleeding. The filter paper become there is no blood spots on the filter paper. We count the bleeding time by this method. The other methods that are done in the laboratory also is the prothrombin time, which is what is a prothrombin time referred to, along with its derived measures of prothrombin ratio and INR, which is important in the international normalized ratio, are assays evaluating the extrinsic pathway and common pathway of coagulation. You know very well that is the as you know, we and understand it from the term 1 in hemodynamic that we discuss the extrinsic pathway and intrinsic pathway. The extrinsic pathway, how we assess this by prothrombin time. It is the lab test that we evaluate the extrinsic pathway, but at the same time the common pathway of coagulation. This test is also called ProTime INR and PT INR. They are also used to determine the clotting tendency of the blood, and also in such a patient when they are intake warfarin for as anticoagulant. It is important to measure the dosage of the warfarin in patient with liver damage, because you know the vitamin K are produced by the liver and vitamin K status. So the prothrombin measured the following: coagulation factor, also as in fibrinogen 1, prothrombin 2, factor 5, and factor 7 and factor 10. The other tests which are used in the lab to evaluate the coagulation status or the function of the coagulation factors in the body is partial thromboplastin time. This measure overall speed at which the blood clot by mean of 2 consecutive series of biochemical reaction, known as the intrinsic pathway and common pathway of coagulation. So this is partial thromboplastin is important to assess the coagulation or the biochemical reactions of the coagulating factors or coagulation factors the intrinsic pathway, at the same time in common pathway. Partial thromboplastin time, PTT, measure the following factors: fibrinogen 1, 2, 5, 8, which is antihemophilic factor, is important, and 10, and plasma, and 11 and 12, plasma thromboplastin and Hagman factor. All these coagulation factors are assessed by partial thromboplastin time. Thrombin time is another test, also known as thrombin clotting time. This is a blood test which is used to measure the time it takes for a clot to form in the plasma of a blood sample containing anticoagulant after an excess of thrombin that has been added. It is used to diagnose coagulation disorder and also to assess the effectiveness of fibrinolytic treatment or therapy. But most commonly, the blood test that used the initial blood for the bleeding tendency, most commonly used in the medical practice when the patient has bleeding tendency in the form of ecchymosis or petechiae or purpura, or patient has epistaxis or menorrhagia, and that the physician suspect that the patient might have a bleeding tendency, or in case of patient has intaken anticoagulant drug as warfarin in order to adjust the dose of the drug and to see if this drug is effective in such patient, because we will not only peak prothrombin time but also the INR will be measured at the same time. Also, what else? And the other coagulant patient might have the family history of the hemophilia to assess the amount of the factor 8 in the blood. All of these should be assessed by laboratory. Platelet count by bleeding time that I discussed in the previous lecture. The prolongation is seen in a platelet disease, as in the decrease in the amount of the platelet, such as in the count when the platelet count is low, so the bleeding time will prolonged. Also might be prolonged in certain as a side effect of the certain drugs, as aspirin or other anticoagulant that given to the patient due to the patient have risk of myocardial infarction or angina or heart disease or stroke. So the physician give the patient this drug, antiplatelet drug. So this might cause the prolongation of the bleeding time. Partial thromboplastin time prolongation is seen in hemophilia or in patient also in lupus anticoagulant. Prothrombin time prolongation also seen in the factor 7 deficiency, while the factor 5, 10, 2 prothrombin fibrinogen, both PT and PTT are prolonged because they share the common pathway. Thrombocytopenia. This topic refers to the low platelet count. Someone of you might ask, what is the normal platelet count? It's 150,000 to 450,000 per cubic millimeter. Thrombocytopenia, characterized by spontaneous bleeding with prolonged bleeding time and normal PT and PTT. Platelet count of 100,000 or less is generally considered to constitute thrombocytopenia. It is considered thrombocytopenic patient. Less patient platelet count of 100,000 or less. But if it is 20,000 to 50,000, it is associated, the patient is, this count, little platelet count, are associated with increased risk of post-traumatic bleeding. A patient hit by something or by it is exposed to trauma, it leads to the bleeding, and not only bleeding, it might be it's not unable to stop. This bleeding is unable to be stopped, and not easy to be stopped because of the low platelet count. While below 20,000 cell, the patient might develop spontaneous bleeding even without a trauma. Patient might have bleeding per nose epistaxis, if she is female, menorrhagia. Large area of the skin has ecchymosis, ecchymotic spots, petechiae, purpura, bleeding per gum, spontaneous bleeding without any trauma, without any things to induce this bleeding. Most bleeding in thrombocytopenia occur from small superficial blood vessels and produce petechial or large ecchymotic spots in the skin, mucous membrane of GIT, of the urinary tract, or in any site actually of the body. Sometimes larger hemorrhage might cause certain major hazard actually to the patient when the platelet count profoundly depressed or decreased, such as the bleeding that is central nervous system. This is one of the major hazard or major risk that the patient might take when he has low platelet count. This is a petechiae, just small spot. I think we had these pictures, and we have the same in the term 1, and we discuss it thoroughly. This is purpura, actually the larger than petechiae, larger spot than petechiae. When petechiae 1 to 2 millimeter, purpura more than 3 millimeter, and ecchymosis very large, or more than 1 to 2 centimeter large ecchymotic spots in the skin and mucous membrane, which appear as blue discoloration of the skin. While here the petechiae is pinpoint spots on the skin and the mucous membrane. This is also petechial hemorrhagic spots in patient with the thrombocytopenia. This is a skin ecchymosis, ecchymotic spots, larger hemorrhagic spots on the skin of the patient that have thrombocytopenia. What are the causes of thrombocytopenia? First of all, is when decreased in the production of the platelet. You know, the platelet dropped from megakaryocyte, arises from the progenitor of the platelet, from the megakaryocyte in the bone marrow. So when there is abnormal in the production or decrease in the production of the platelet, common sense, it is there is something wrong in the bone marrow that lead to the cessation of the production of this from the factory. In cases of aplastic anemia, which is when there is suppression of the allostem cells to produce the blood elements, or in the form of the leukemia, maybe due to the leukemia, which is will be discussed thoroughly in the lecture 7 and 8, or in the case of metastatic tumors, as in the case of the cancer, or that metastatic cancer that when the tumor metastasizes to the bone marrow, it will affect the function of the bone marrow, so it will lead to the decrease in the platelet production, or in the form of the infection as in tuberculosis or any type of the infection that might involve the bone marrow, as in tuberculosis or any granulomatous lesion that might involve the bone marrow. Sometimes the production is good and is fair. There is no problem in the production, but the problem here is in the destruction in the platelet out of the bone marrow. What does that mean? That the factory is working and it produces a platelet, but there is something wrong in the circulation or in the elsewhere in the body. يعني شيء يكس يعني كيف حقولكم إنه الفاكتوري is working بس البليتلت الأقراص الدموية somewhere in the body is destroyed. This is especially in the idiopathic or autoimmune thrombocytopenia purpura. Autoimmune idiopathic thrombocytopenia purpura, most commonly this is due to the certain viral infection preceded by viral infection, maybe flu-like illness, 1 or 2 weeks, and then the patient, flu-like illness, any viral upper respiratory tract infection or any viral infection, and then afterward it will lead patient presented that have petechiae or purpura or ecchymosis or bleeding pernose or whatever. So when he is the patient, when we investigate, we found that the patient has a history of the flu-like illness or the fever or upper respiratory tract infection, viral infection. This might induce production of the autoantibody against the platelet, so which lead to the destruction of the platelet and subsequently will lead to the decrease in the platelet count in the blood. Sometimes non-immune, there is no autoantibody, but there is mechanical destruction of the platelet. As in DIC, disseminated intravascular coagulopathy, you know very well what is disseminated intravascular coagulopathy. Disseminated intravascular coagulopathy. Actually, it is a clinical disorder in which there is, it is end result of many clinical situations, which is severe, as we discussed it in the first term, severe illnesses like burn, like septicemia, like any respiratory distress syndrome, any disease might severe bleeding, postpartum bleeding, obstetric complication, many of these serious severe illnesses and procedures might lead to the DIC, in which the consumption of the platelet is because there is disseminated intravascular coagulation in which there is a bleeding and coagulation, so consumption of this platelet would be high in such a disease. Sometimes trapping of the platelet on the clot, not only consumption, trapping of the platelet, adhesion of the platelet into the clot, which lead to the decrease in the amount of the platelet in such a diseases. Thrombotic thrombocytopenia purpura and HUS also, hemolytic uremic syndrome also. This is, I think we got this also disease in the first term. This disease is due to the certain type of the bacteria, actually, Shigella. One day it happened as an epidemic also because contamination of the beef burger with that type of the bacteria, which lead to the diarrhea and then to the hemolytic uremic syndrome, which is also associated with the thrombocytopenia. Sometimes in case of hyperseplenism, there is sequestration of the platelet, so up to 90% of the platelet in such a condition destroyed. Idiopathic thrombocytopenia purpura can be acute or chronic. Acute, caused by formation of antiplatelet antibody. It is disease of childhood, most commonly in the kids, both in male and female. Have abrupt onset, preceded by viral infection, as I just discussed this to you. It takes 2 weeks for the purpura to develop. It is preceded by history of upper respiratory tract infection or any type of the flu-like illness. It is self-limited, resolved spontaneously within 6 months. 20% of cases develop chronic ITP, sometimes not resolved within 6 months, so it would develop or this is a photograph of the patient with the severe periorbital ecchymosis due to the ITP, idiopathic thrombocytopenia purpura. A chronic ITP often occurs in adults, more common in the female, more than 40 years. Female is to male ratio is about 3:1. This is more commonly occurs in the systemic lupus erythematosus, in the autoimmune disease, in the AIDS patient, sometimes a side effect of the certain drugs, or might be due to the viral infection or followed viral infections. It's also characterized by the bleeding in the skin, petechiae-like, or purpura in the lower limb, mucosal and the nasal bleeding, or in the gum, or patient develop hematuria. It is due to the autoantibody against the surface membrane. The opsonized platelet are susceptible for splenic phagocytosis. So platelet with antibody, it will be plucked out by the macrophages in the spleen, then it will be destroyed. 70 to 80% resolve or improve after splenectomy. Thrombotic thrombocytopenia purpura, it is a rare condition of unknown cause or obscure nature, characterized by thrombocytopenia, microidiopathic hemolytic anemia, fever, and transient neurological deficit and renal failure. The cause include deficiency in von Willebrand factor, metalloprotease, ADAM, TS13, enzyme deficiency, result accumulation of very high molecular weight multimer of von Willebrand factor. So this will promote platelet microaggregation in the arteriole, in the capillaries, and in the venules throughout all organs and tissue in the body. More commonly occurs in young adult female than males. In this picture, we see this is a normal hemostasis, while here this is a normal hemostasis. When this is a von Willebrand factor and this is the platelet. This is a glycoprotein 1b when there is the site of the combined with the von Willebrand. When there's this is prevent more aggregation. This is normal hemostasis. While here, when there is a mutation in the ADAMS, which is the von Willebrand metalloproteinase enzyme, or there is anti-ADAM TS13, so it will lead, it will lead to the accumulation and of the von Willebrand factor, because there is no enzyme, the metalloproteinase, to prevent this aggregation, which lead to the more aggregation of the von Willebrand and the platelet, which lead to the thrombotic thrombocytopenia purpura. Microidiopathic hemolytic anemia. The pathogenesis of this anemia: red blood cells damaged when passing through obstructed or narrowed blood vessels. This might be seen in DIC when there is fibrin clots obstructing blood vessels, so there will be mechanical destruction or damage to the red blood cells. or thrombocytopenia purpura, thrombotic thrombocytopenia purpura with the hemolytic uremic syndrome, or in the malignant hypertension, or in the SLE. In this picture, which is the blood smear from the young female with recent diagnosis of thrombotic thrombocytopenia purpura with marked thrombocytopenia and hemolytic anemia. Actually, it is microangiopathic hemolytic anemia showing schistocytes. This is a schistocyte or helmet cells due to the destruction of the schistocyte, due to the destruction of red blood cells in patient with maybe hemolytic uremic syndrome, maybe due to the DIC when passing the red blood cell are passing through narrowed obstructed blood vessels. Hemolytic uremic syndrome, non-immune thrombocytopenia, most commonly seen in pediatric population. The most common cause is E. coli, certain type of the bacteria, strain 157H7, toxin-induced endothelial damage. The other type of bacteria, as Shigella, also caused this epidemic one day to the camping student who ingested contaminated beef burger, contaminated with this type of the bacteria, which lead them to the bloody diarrhea associated, and then later on develop renal failure, acute renal failure. Platelet microaggregate hyaline microthrombi, which is usually limited to the glomerular capillary. Patient presented with the thrombocytopenia, microangiopathic hemolytic anemia, and acute renal failure. PT-PTT normal, but the bleeding time elevated because the thrombocytopenia consumed or in the by forming microthrombi in the glomerular capillary, so bleeding time prolonged. This is the complement activation, which is the common pathway for thrombotic thrombocytopenia purpura and atypical hemolytic uremic syndrome and the hemolytic uremic syndrome. Through the Adams TS13 when there is heat deficiency or there is a blockage of the Adams 13 cleavage site or defective in the complement regulator factor decrease, which lead to the decrease in the ADAM according to the type of the disease that cause the complement activation. When there is complement activation, lead to the platelet attachment, activation, aggregation, adhesions. So to the von Willebrand factor and activation, which is lead to the direct red blood cell damage because of the thrombus formation, which is thrombus including the blood vessels, which lead to the direct might lead this mechanism might lead to the direct injury to the red blood cell, or through thrombotic microangiopathy when there is injury to the red blood cell when it's passing through the occluded blood vessels, or through and cause endothelial cell injury. This is also the mechanism of the complement activation, which is the common pathway of this disease. Now we are coming to the DIC, disseminated intravascular coagulopathy. We will discuss it. We will pass quickly on this topic actually because we spent a lot on it in the term one, but just to be mentioned here in order to because it is one of the important disorders that is that cause impairment or dysfunction in the coagulation. It is characterized by widespread clotting and microthrombi, resulting due to the resultant consumption of the platelets and coagulation factors, especially factor 2, 5, and 8, and fibrinogen. Clinically, patient presented with thrombosis and bleeding. You remember the thrombotic phenomena and bleeding. A feature may include microangiopathic hemolytic anemia with the schistocyte fragmented red blood cells or helmet cells, Also increase in the fibrin and fibrinogen degrading product, and also decrease in the platelet count, thrombocytopenia, prolongation of the PT, PTT, thrombin time, and bleeding time. Actually, all the coagulation factor affected in this disorder in the IC, as all of them are consumed in the thrombotic phenomena and in the bleeding. Microthrombi, widespread. It is characterized by widespread microthrombi in the small blood vessels of many tissue and organs. Causes include increase of tissue thromboplastin, actually tissue factor, or activation of intrinsic pathway, as well as secondary activation of the fibrinotic pathway. You remember, this is especially tissue thromboplastin activation or release during the obstetric emergency or labors, which is one of the complication of the obstetric delivery that might lead to the DIC in some of the patient. This DIC, so the activation, the tissue thromboplastin is activated in such a patient. And the bleeding, in those patients, bleeding is more prominent and profound than thrombotic phenomena. Most commonly in the obstetric, as I told you, complications such as toxemia, amniotic fluid emboli, retention, dead fetus, or abruptio placentae. It might also associated with some types of the cancer, such as in the lung, in the pancreas, because of the hypercoagulability status of such a cancer patient might be high in certain types of the cancer, prostate or stomach. Also, might be due to the tissue damage by infection, especially gram-negative septicemia and the trauma. This is a diagram showing disseminated intravascular coagulopathy, DIC. When the DIC takes place or occurs when there is severe endothelial injury, as any trauma which cause endothelial injury, which lead to the platelet aggregation, because endothelial injury lead to the exposure of von Willebrand factor, so the platelet will aggregate, lead to the adhesion and aggregation of the platelet. This will lead to the widespread microvascular thrombosis in conjunction with the release of tissue factors that lead to the activation of the coagulation cascade. Sepsis also, septicemia, تسمم الدم, lead to the release of tissue factor, which lead to the widespread microvascular thrombosis. Product of conception, as in obstructed labor, also one of the emergency that will lead also to the release of the tissue factor which are present in the placenta. And massive tissue destruction, as in the trauma or in the accident or in any muscular crash, maybe due to any reason which lead to the release of tissue factor. And you know, the tissue factor lead to the activation of the coagulation cascade, which lead to the widespread microvascular thrombosis, which lead to the vascular occlusion, انسداد بالشرايين. This vascular occlusion will predispose to the microangiopathic hemolytic anemia when the red blood cell or the blood pass through this occluded blood vessels, the red blood cell injured becomes schistocyte or helmet cell, which is lead to the microangiopathic hemolytic anemia. At the same time, when there is a thrombosis, the body should defend itself by activation of the plasmin in order to remove this thrombosis. In such a case, it will lead to the activation of the fibrinolytic pathway. So it will lead to the fibrin split product. Here we have two mechanisms in this DIC. Thrombosis, widespread thrombosis, in addition to the fibrinolysis. So both occlusions of the blood vessels by thrombus in addition to the bleeding. This is the characteristic of DIC. And from this point, the damage or the failure of the tissue and the organs and the ischemic changes in the tissue in addition to the bleeding arise. Consumption of the here, consumption, as we said, consumption of the clotting factors and the platelet will lead to the bleeding, in addition to the activation of the plasmin and fibrinolysis also lead to the bleeding. Two mechanisms take place in DIC. This is the triangle showing the spectrum of disseminated intravascular coagulopathy, DIC. It includes in one of its ends, fibrinolysis, in which there is hemorrhage, hematuria, GI bleeding, vaginal bleeding, wounds, puncture site bleeding, associated with the anemia and shock. At the other angle or the other end, showing thrombocytopenia because of the consumption of the platelet. So it presented as a purpura and a chemosis. And here at the other end of the triangle, it's showing coagulation, consumption of the coagulopathy and activation of coagulation factors which lead to the thrombosis, stroke, gangrene, infarction, renal cortical necrosis, and then renal failure. Now we are coming to the disorder of one of the coagulation factor, which is important and considered one of the most commonest disorder or deficiency in the coagulating factor. Among the coagulating factor, it is factor VIII deficiency and von Willebrand factor complex. It's called hemophilia A and von Willebrand disease. This is caused by qualitative and or quantitative defect that involve the factor VIII or von Willebrand complex. Circulating factor VIII binds to the non-covalently to the von Willebrand factor. Endothelial cells are the major source of the plasma von Willebrand factor, where most factor VIII is synthesized in the liver, as other coagulating factors that are synthesized in the liver, while the von Willebrand factor is already synthesized by the endothelial cells. Von Willebrand factor, or VWF factor, is found in the plasma in association with factor VIII, in platelet granules, in endothelial cell, and within cytoplasmic vesicles, which is called wobble pad bodies, and in the subendothelium where it binds to the collagen. When endothelial cell stripped away, or it is injured or stressed by any stressful injury or by any trauma, the subendothelial von Willebrand factor exposed. When this factor is exposed, it binds to the platelet through glycoprotein 1b and to a lesser degree through the glycoprotein 2b and 3a. So the most important function of the von Willebrand factor is to facilitate the adhesion of the platelet to the damaged blood vessel wall. So it is very important, this factor, to adhesion of the platelet in order to stop bleeding. In addition to its role in the platelet adhesion, von Willebrand factor also stabilizes factor VIII. This is another function of the von Willebrand factor. Thus, von Willebrand factor deficiency will lead to the secondary deficiency of the factor VIII. Here is the this picture showing the factor 8 von Willebrand complex. Look at here, it is subendothelial von Willebrand factor. This is the endothelial, this is the blood vessels. This is circulating factor, von Willebrand factor with the factor 8. The structure and function factor 8 von Willebrand factor complex. Factor 8 is usually synthesized in the liver and the kidney, but mostly in the liver. The von Willebrand factor is made in the endothelial cell, as well in the megakaryocytes. The two associate to form complex in the circulation. This is the complex. This is a von Willebrand and this is the factor 8. So, von Willebrand factor is also present subendothelial matrix of the normal blood vessels. So, when there is endothelial injury, when there is damage to the endothelial cell, it will lead to the exposure of this von Willebrand factor, which cause adhesion of the platelet. Primarily via glycoprotein platelet receptor 1b, circulating von Willebrand factor and von Willebrand factor released from the alpha granule of the activated platelet can bind exposed subendothelial matrix, which is cause further platelet adhesion and activation. So the activated platelet from the hemostatic aggregate fibrinogen also, because here when there's von Willebrand factors with the factor 8, when it's activated, it will lead to this is factor 10 to factor 10A, which is lead to the activation of the clotting cascade, which lead to the fibrinogen convert to the fibrin, and then it will aggregate with the platelet. So the fibrinogen participate in aggregation through bridging interaction with the glycoprotein 2b and 3a, 2b and 3a through the fibrinogen. Here the fibrinogen, which is activated by the activated clotting cascade. So this is the platelet, and this is through the 2b, which is here, this is a 2b and 3a receptor in the platelet. It more aggregation and more contribute in the aggregation with the platelet. Factor 8 take part in the coagulation cascade as a cofactor in the activation of the factor 10 on the surface of the activated platelet. On the surface of the activated platelet, this is factor 8, which is activated factor 8, lead to the activation of the factor 10 and to the 10A, as I told you, which is lead to the starting of the clotting cascade, which is lead to the formation of the consequently to the fibrinogen, which is and it's the fibrinogen cause or unite or precipitate or combined with the receptor on the platelet, which is cause more aggregation in order to close or to be plug the injured endothelial cells. This is a factor 8 and von Willebrand factor complex mechanism. Von Willebrand disease, the most common hereditary bleeding disorder. There are multiple types, type 1, 2, and 3. The 1 is a classic, most common, quantitative defect. The quantity defect in the quantity of von Willebrand. 2. In the type 2, there's 4 subtypes, which is a qualitative defect of intermediate severity. Type 3 is extremely severe with virtually no von Willebrand factors. There is totally absent. Most cases show autosomal dominant inheritance. However, type 3 and some cases of type 2 are autosomal recessive. The characteristic features of the von Willebrand disease include impaired in the platelet adhesion, as von Willebrand is very important to the adhesion of the platelet. So when there is impairment in the function of the platelet, it will lead to the prolonged bleeding time, and at the same time, functional deficiency of the factor VIII. We have factor VIII, but we don't have von Willebrand disease, which is important to stabilize factor VIII, which lead to the functional defect in or deficiency in the factor VIII. The patient presented with spontaneous bleeding from mucous membrane, maybe from the wound, from the venipuncture, menorrhagia, intrauterine bleeding, sometimes prolonged bleeding time in the presence of normal platelet count, because here we don't have decrease in the platelet count. Actually, the problem here in the function in the adhesion of the platelet, which is caused by the defect in the von Willebrand disease. Factor VIII deficiency. Hemophilia A. Classic hemophilia. Hemophilia is the most common hereditary disease associated with a serious bleeding. It is X-linked recessive disorder that caused by the reduction in the factor VIII activity. X-linked mean that most of the patients are male, because male XY. So when he has diseased X, it's already the patient become diseased. While the female has XX. So when she has disease only one chromosome, only one X disease, she will carry the disease to her sons, but she doesn't show the disease. So only carrier. Only when she got two diseased X-linked or two X chromosome are diseased, so she will get the illness. It primarily affects the male, as I told you, but much less commonly excessive bleeding also in homozygous females. Okay. Characterize the patient by bruising and massive hemorrhage spontaneously in area exposed to trauma, especially in the joint, which is called hemarthrosis. There is bleeding inside the joint. Normal bleeding time, because the platelet count is normal, while the PT and PT with a prolonged partial thromboplastin time. So here we do lab investigation to make for the investigate of those patients. Bleeding time is normal, and platelet count and PT prothrombin time is normal, while prolonged of the PTT. Here is the photographic view of the picture showing the child with hemophilia, which showing the bleeding in the joint and the swelling of the joint. It is hemarthrosis. Factor IX deficiency, which is hemophilia B, Christmas disease. When there is severe factor IX deficiency, it is an X-linked disorder that is indistinguishable clinically from the hemophilia A, but it is much less common. The partial thromboplastin time is prolonged and the bleeding time is normal. The diagnosis of Christmas disease depends on the specific assay of the factor IX. Here we are coming to the splenic disorders. The first topic in this, which is important, topic is the splenic rupture. The splenic rupture is considered one of the important emergencies and should be seriously managed, because when the spleen rupture it will lead to the intra-abdominal bleeding, which lead if it's not treated promptly, it will lead to the shock and death of the patient. The treatment of choice is surgical, but as long as the spleen rupture, so it should be removed surgically, and of course the patient should be managed by, if he is if he is losing a large amount of the blood, should be given according to the status, given blood transfusion in order to compensate what is lost. What is the conditions that is associated with splenic rupture? There are certain infection actually, or might be not only infection, it's the infections and some of the malignancies, blood malignancies, that also might lead to the rupture. And also the most important things is the trauma. Actually, the trauma, when a patient exposed to trauma, fall on his abdomen, or there is hit on his abdomen, or there is a fracture of the ribs on the left side of the left side of the abdomen or the chest, might lead to the rupture of the spleen. Any blunt trauma to the abdomen, any hit, any fall from the height might lead to the rupture of the spleen. The infections that might lead to the rupture of the spleen, because the spleen become splenomegaly, or the spleen becomes so fragile, so it might lead to rupture. Infectious mononucleosis, malaria, typhoid fever, and the lymphoma, all of these, and trauma, all of these contribute as causes that lead to the splenic. This is a ruptured spleen, so it will be removed as soon as possible in order to prevent the patient from reaching the shocked status. What is the hypersplenism? Hypersplenism, it is a state that can be associated with many of the diseases that affecting the spleen. Large spleen often remove the excessive number of one or more of the formed element of the blood, such as red blood cells, white blood cells, and platelet, which resulting in thereby we have anemia, leukopenia, the thrombocytopenia. In addition, the platelets are more susceptible to sequestration in the interstices of the red pulp, to be sequestrated in the red pulp. So as a result, the thrombocytopenia is more prevalent and severe in the individual with splenomegaly than anemia and neutropenia, because it is more susceptible, the platelet more susceptible to be sequestrated in the interstices of the red pulp. So the thrombocytopenia considered is more common feature of the splenomegaly. What are the causes of the splenomegaly? We have three categories according to the weight of the spleen. Massive splenomegaly, when the weight more than 1,000 gram, when the moderate is between 500 to the 1,000 gram, and small less than 500 gram. In massive splenomegaly, it is the most characteristic in chronic myeloid leukemia, CML, myelofibrosis, hairy cell leukemia, and malaria. In moderate, when patient has portal hypertension, such as in the portal hypertension when there is the pressure and the portal circulation is increased, such as in the patient with the cirrhosis, liver cirrhosis. For any reason of the liver cirrhosis, we don't want to get through this topic because you will take it next year. Or in case of the lymphoma, any case of the lymphoma might lead to the moderate splenomegaly, leukemia also, thalassemia also, and glycogen storage disease. Small splenomegaly, it is the spleen is large, but the weight is still less than 500 gram. Polycythemia rubra vera, hemolytic anemia, infectious mononucleosis, malaria. However, these two are associated with ruptured spleen and connective tissue disorder, amyloid and sarcoidosis. Thymus. Now we are coming to the new topic and a new glands and organ, which is a specialized primary lymphoid organ of the immune system, within it. There's T cell mature, and T cell are important, critical to the adaptive immune system, where the body adapts specifically to foreign invaders. The thymus is composed of two identical lobes that located in the anterior superior mediastinum, in the front of the heart and behind the sternum. As I think that you already have been covered the thymus, the location of the thymus, anatomical location of the thymus in anatomy and the function of it also in the physiology. But now we have to highlight on some point, on some aspects of the thymus in order to understand the disease that take place or develop in this gland. As it's located in the anterior superior mediastinum in the front of the heart, so any tumor in the superior mediastinum or in any mass that might cause a pressure effect on the nearby structures, to the superior vena cava, shortness of breath. The thymus should be considered one of the causes, or the thymoma or the hyperplasia of the thymus should be considered in the differential diagnosis of this symptoms. Each lobe of the thymus can be divided into central medulla and peripheral cortex, which is surrounded by the outer capsule. The cortex and the medulla play different roles in the development of T cells. The cell in the thymus divided into thymic stromal cells and the cell of hematopoietic origin, which derived from the bone marrow resident hematopoietic stem cells. Developing T cells are referred to the thymocytes and are of hematopoietic origin. Stroma cells include epithelial cells of the thymic cortex and medulla and dendritic cells. It's well known that the role of the thymus in T cell differentiation, thus thymus will be involved in the lymphoma of the T cell lineage. Actually, this lymphoma of the T cell lineage is mostly take place or develop in the children, and it is named as acute lymphoblastic lymphoma or acute lymphoblastic leukemia of T cell origin, which is most commonly developed in the thymus. Thymic hyperplasia is another reactive disease that develop in the thymus. It is seen usually in the patient with myasthenia gravis, which is characterized by the lymphoid hyperplasia with prominent germinal center that's seen in the thymic medulla, and these follicles contain B cells. The thymic hyperplasia and the thymoma is sometimes seen in the autoimmune disease as in systemic lupus erythematosus and in the rheumatoid arthritis. Now we are coming to highlight on myasthenia gravis, which might be caused by the thymic hyperplasia or might be due to the thymoma. It is a neuromuscular disease with varying degree of skeletal muscle weakness. Most common muscle that affected in the eye and face and swallowing. The most common symptom, which is actually a varying degree of muscle weakness, patient double vision, drooping of the eyelid, patient unable to open his eye because of the drooping of the eyelid, trouble in the talking, trouble in the walking. The onset might be sudden or might be insidious according to the cause, whether this is maybe due to the thymoma or maybe due to the thymic hyperplasia. It's an autoimmune disease, result of the antibody that block or destroy nicotinic acetylcholine receptor at the junction between the nerve and the muscle. So this will lead to the prevention of the nerve impulse from triggering muscle contraction. As we say that the symptoms, there is a varying degree of the muscle weakness, double vision, drooping eye, trouble walking, trouble in the talking, and the treatment of choice, of course, if it is the thymoma, or surgical removal of the thymus, even the thymic hyperplasia, surgical removal of the thymus, or plasmapheresis, because due to the autoantibody to the nicotinic acetylcholine. This is a patient, photograph of the patient with the drooping of the eye and with the eye deviation in patient with the myasthenia gravis, and the patient tried to open his eye but is unable to open his eye. The thymoma, which is tumor result from epithelial cell, thymic epithelial cell, it's called thymoma. Very often develop in patients older than 40 years of age, 40 or between 40 and 60. Tumor are generally detected when they have symptoms such as in the neck pressure in the neck, or there is shortness of breath, or there is neck mass, because the thymus in the superior anterior mediastinum, so it will lead to the pressure effect on the nearby structures such as supravenae cava, or in the esophagus, or in the cuff, maybe cuff reflex, because the pressure on the bronchi, or maybe due to the, because it's anterior to the heart, so it will be, might cause patient feel heaviness in the chest, or might be due to the patient presented with myasthenia gravis, in which patient there is muscle weakness. So when muscle weakness, and there is during the examination or investigation of the patient, and with myasthenia gravis, we might detect that the patient has thymoma, because you know that myasthenia gravis may be due to the hyperplasia or thymoma, or might be due to the incidental finding without any cause by chest X-ray or by CT scan. Both, as we say, that tumor and hyperplasia that originate from the thymus are associated with the autoimmune disease such as hypogammaglobulinemia, Graves' disease, thyrotoxicosis, pure red cell aplasia, pernicious anemia, dermatomyositis, because there is defect in the negative selection of the proliferating T cells. The tumors of the thymic epithelial cells might be benign or malignant, and the malignant is divided into type 1 according to the behavior, or type 2. The benign thymoma, encapsulated, is confined, the tumor confined to the thymus, lobulated, firmly gray, white mass, consisting of spindle-shaped cells with the lymphocyte, T lymphocyte, but it's confined to the capsule, inside the capsule. It's not, and it's benign looking. In malignant type of thymoma, which has two type 1 and 2, this is cytologically benign, but the behavior is infiltrative, so it's infiltrate beyond the capsule. It's locally aggressive. But here the type 2, the cytologically and biologically are malignant with the high rate of metastasis, and can look like squamous cell carcinoma. This is a hyperplasia in which patient have follicular hyperplasia. It's lymphoid tissue. So this is the germinal center, and this is the mental zone. And this is a reactive follicle, different size of the follicle, actually, involving the thymus. This is a gross section of the thymoma. This is a thymoma. As I think this is the more infiltrative, so it's malignant looking because of the infiltrative pattern of the shape of the tumor, that it is white, yellow in color with infiltrative margin. So most likely this is a malignant. This is a gross section of the thymoma, encapsulated thymoma, which composed of the mixed lymphocyte and epithelial. This is the capsule of the thymoma. This is a tumor of the thymic gland. This is a gross section, look like lobulated, encapsulated. So when it's encapsulated, either it's benign if confined to the capsule and is composed of the spindle cells and the T lymphocyte, or might be malignant but of the type 1 malignancy, in which there is an infiltrative, if it's not infiltrate the capsule, if it's just infiltrate the capsule, locally invasive with still bland looking epithelial cells, but it is locally infiltrative. So according to the histopathological examination of this tumor, we can decide whether it is benign or malignant. This is a malignant thymoma also, which is composed of epithelial cells with a few scattered lymphocytes, T lymphocyte at the border, but it is look like squamous epithelial cells. Now we are coming to the polycythemia, when there is large or increase in the red blood cell mass, and white blood cell disorders, including leukopenia and leukocytosis. Polycythemia. What is the polycythemia? It's referred to increase in the concentration of red blood cell mass per unit volume of the peripheral blood, usually lead to the increase in the hemoglobin level. Normal red blood cell count about 4.2 to 5.8 million cell per cubic millimeter in the male. In the female, in between 3.6 to the 5 million per cubic millimeter. This is a variation in the between gender variation. Hemoglobin level normally in the male in between 13.6 to the 17.2 gram per deciliter in the male, while in the female is about between 12 to 15. PCV, or paxial volume, 40 to 50% in the male, 36% to 45% in the female. When there is increase in the red blood cell mass and the concentration per volume of the blood, which is referred to the polycythemia, it can be relative polycythemia or it is absolute polycythemia. What is the meaning and what is the difference in between two? Relative, it occurs when there is loss of the plasma volume without corresponding loss of red blood cells, as in the hemoconcentration. There is an apparent but not real increase in the number of red blood cells in the circulation, but because the plasma volume is decreased, this is most commonly when patient with deprivation of the water, in the burns, in the shock, in the vomiting, and diarrhea, all these might lead to the relative polycythemia. Red blood cell is not increased, but relatively to the plasma volume is increased because of the loss of the plasma volume. This is seen in the deprivation of the water, such as in the fasting, when we are fasting, when in the hot weather, when there is loss of water for any reason, loss of the body fluid, in the vomiting, in the diarrhea, in the sweating. Sometimes adrenocortical insufficiency leads to the loss of the electrolyte and loss of the plasma volume, and also in severe situation as in the burns, and in the shock. Absolute polycythemia. This is a real one because there is a real increase in the red blood cell mass due to the proliferation, autonomous proliferation of the myeloid stem cell. And when the red cell progenitors are proliferating in response to an increase in the erythropoietin. Here, in such a case, the erythropoietin increase, so it will lead to the autonomous proliferation of the myeloid stem cell and red blood when the red blood cell progenitor are proliferating in response to it. Might be primary, idiopathic, or might be secondary, associated with other diseases. Primary, called polycythemia rubra, when the abnormal proliferation with of the myeloid stem cell with normal or low erythropoietin level. Polycythemia rubra, it is characterized by neoplastic proliferation of multipotent myeloid stem cells, which result in increase in the erythroid, in the granulocytic and megakaryocytic element. Its increased marrow production is reflected in the peripheral blood in the form of erythrocytosis, polycythemia, increased red blood cell mass, because there is a neoplastic proliferation of the myeloid stem cell or red blood cell progenitors or erythroid progenitor cells. It's also lead to the granulocytosis, increase in the amount of white blood cells and increase in the amount of the platelet. All of these or myeloid stem cell, multipotent myeloid stem cells are proliferating, so it will lead to the increase the elements of the blood. Absolute increase in the red cell mass that is responsible for the clinical symptoms. The pathophysiology of the polycythemia. In polycythemia rubra, the progenitor cell require extremely small amount of erythropoietin and other hematopoietic growth factor, which is required for the proliferation. So, the level of the serum erythropoietin is undetectable, normal or slightly increased. The bone marrow is hypercellular. There is increase in the number of erythroid progenitor cells, accompanied by increase in the number also of the granulocytic and megakaryocytes precursors, or the granulocytic site precursors and megakaryocytes. This is a bone marrow view in patient with the polycythemia rubra, in which it is hypercellular would increase all the hematopoietic elements, including the megakaryocytes, erythroid, and granulocytic precursors. In the peripheral blood examination, we see that there is marked increase in the PCV hematocrit value, normal, it's about 60% or more. The hemoglobin concentration, it's ranged between 16 to 28 grams per deciliter, very high level. Increase in the white blood cell count, maybe as high as 50,000 per cubic millimeter, which is very high. Normally, it's about up to that 11,000. More than 11,000, it is considered it is high leukocytosis. But here in the polycythemia, might reach in 50,000. Increase in the red cell volume, it leads to the slowing of the blood flow and vascular distension and stasis, and the excessive blood is trapping in the venous circulation. So those patients with the polycythemia liable to have thrombosis and stroke or myocardial infarction or CVA because of the slowing of the blood supply. The red blood cells mass is high, so the red blood cells become close to each other. So increase the incidence of the thrombosis, infarction, and ischemia in such a patient. This is a blood film in patient with polycythemia rubra, in which this look at the platelet It's thrombocytosis. In addition to the red blood cell, which overlapping each other, it is high red blood cell, large red blood cell mass, the PCV high in such a patient. This is a neutrophil, this is a eosinophils, and this is a, look at this, is it is a, as I think it is giant platelet. This is giant platelet, and this is the platelet. This is a patient. This is a platform of the patient with the polycythemia. Clinically, those patients usually affect the patient, more common in the male, of course, and it is affect the middle age and elderly, mean about 60 years of age. Insidious onset. The patient plethoric، لونه يصير محتقن أحمر، الشخص يكون محتقن بلون أحمر and cyanotic، أحمر على مزرق يعني because of the high red blood cell mass. Patient in 70% of such patients are hypertensive. Patient complaining of headache, dizziness, and itching, intense pruritus. And of course, in those patients, increase the incidence of bleeding and thrombosis. 25% of the cases have the risk of the DVT because of the stasis, because of the distension of the blood vessels, thrombosis, myocardial infarction, and stroke also. Those patients are more liable to have this complication. Hepatic vein thrombosis, called Buchiari syndrome, also increased, or those patients more liable to have it. 15% to 20% of those cases develop myelofibrosis of the bone marrow and extramedullary hematopoiesis. The death usually results from the bleeding or thrombosis. So here, this is the clinical appearance of the patient with the polycythemia vera, which look plethoric, it's red in color, like because of the red blood cell mass, and congested or cyanotic plethoric، يعني لونه أحمر، وجهه أحمر، يكون دائما محتقن وجهه، and عندهم ضغط عالي، ضغط most of the about 70% of those patients have high blood pressure. This is a hand of the patient with the polycythemia vera also. This is also a plethoric. Now we are coming to the disorders of the white blood cells. Normally, white blood cell count in the normal adult is between 4,000 and 10,000 or up to 11,000. Below 4,000, considered a patient leukopenia, and above 11,000, considered leukocytosis. Differential count, it is neutrophils, which is constitute 40 to 75%, lymphocyte between 20 to 50%, monocyte 2 to 10%, and eosinophils 1 to 6%, and basophil less than 1%. Leukocytosis. What is the meaning of the leukocytosis? It is increase in the number of the white blood cell in the peripheral blood more than the normal range. Causes of the leukocytosis. The main cause of the leukocytosis is the infection, especially neutrophilic leukocytosis infection, which is bacterial infection. Any patient with tonsillitis, pharyngitis, bacterial, there's an abscess, any bacterial infection, it leads to the increase the neutrophilic neutrophils in the blood, which cause neutrophilic leukocytosis. Myocardial infarction also, tissue necrosis, also lead to the leukocytosis. Eosinophilic leukocytosis, there is increased number of the leukocyte, but not neutrophil, it is eosinophils. As we know, all of us, that is asthma, in patient with asthma, allergic reaction, asthma, hay fever also. Hay fever also, this is a type of allergy which occurs in in the weather or in the season like now in spring or in the autumn, the patient presented with rhinitis and conjunctivitis and sometimes urticaria, itching on all over her body. What else? Sneezing. Also, there is a shortness of breath, as there is wheezy chest because of the bronchospasm. Parasitic infection or infestation also contribute to the increase in the level of the eosinophil in the blood. Some of the malignancy, as in the Hodgkin lymphoma, also might lead to the eosinophilia and vasculitis. Vasculitis, which is autoimmune reaction, or it is the inflammation of the blood vessel, actually, might be. So most of them are autoimmune. There are many types of vasculitis, as I think you already covered this in the cardiovascular. Some of them are associated with eosinophilia. This is a blood film in patient with a neutrophilia, increase in the number. This is a neutrophil, which is a segmented neutrophil. There's lobes, increase in the number of the neutrophils this is in the blood, peripheral blood, no more than normal. This is a blood film showing lymphocytosis. This is a lymphocyte. Look at the nucleus. Nucleus is larger than the cell. It is only a rim of cytoplasm. Some of the lymphocyte looking atypical. This can be seen, yes, atypical lymphocyte or reactive lymphocyte can be seen in certain viral infection, especially in infectious mononucleosis. This is a lymphocytosis. And generally, the lymphocytosis are seen in the viral infection. This is eosinophilia. This is eosinophils, bilobed nuclei with the eosinophilic or orange color granules in the cytoplasm of the eosinophils, increase in the allergic condition, or as in the asthma or high fever, or in the parasitic infestation. Basophilic leukocytosis, it's rare, of an indication of myeloproliferative disease as in chronic myeloid leukemia. So when we see high percentage of the basophil in the peripheral blood, we have to be aware that this might indicate something more serious, actually, like myeloproliferative disease, chronic myeloid leukemia, myelodysplastic syndrome, and etc. Monocytosis, increase the number of the monocyte in the blood. It's seen in the chronic infection as tuberculosis, and the rickettsiosis as in the typhus fever, sometime in the malaria, collagen disease as in systemic lupus erythematosus, inflammatory bowel disease as in the ulcerative colitis. All these might contribute to the rise in the level of the monocyte. This is a basophil. Basophils. This is a basophilic granules in the peripheral blood film. This is a neutrophils. This is a monocyte. This is actually this is a blast, because we will see to it myeloblast, because there's a nucleoli in the nucleus, which is obvious here. We will come to it in the last 3 lectures. Leukopenia, when there is a reduction in the number of the white blood cells in the peripheral blood. Causes of the leukopenia might be due to the lymphopenia, decrease in the number of the lymphocyte, which is seen in the certain viral infection or sometimes in the autoimmune disease. The viral infection that we see the lymphopenia as in the HIV infection in the AIDS, immune deficiency viral. Sometimes lymphopenia is seen in corticosteroid therapy or cytotoxic drugs also, or anti-cancer therapy. Some of the autoimmune disease as in the SLE or other autoimmune disease or certain viral infection. Nowadays, in COVID-19 infection, the coronavirus infection are associated with the lymphopenia, actually, which is might be one of the causes that the immunity of the patient is become very low, that the lymphocyte reduced, that they cannot fight the virus. Therefore, the patient progressively deteriorate. Neutropenia, when the percentage of the neutrophil or the count, white blood cell count below normal, less than 4,000, agranulocytosis, due to the ineffective inadequate granulopoiesis, such as due to the suppression of the myeloid stem cell, as in case of aplastic anemia. You remember aplastic anemia, when there is suppression of the bone marrow, might be idiopathic or might be due to the drug or due to the infection. So suppression of all component of the blood, including the neutrophils or white blood cell, or sometimes due to the infiltration of the bone marrow by the infection or by tuberculosis or by infiltration of the bone marrow by the tumors or malignancy. Sometimes drugs, clomfenicol, anti-cancer agent, immune suppressive therapy, all of these drugs lead to the suppression of the level of the neutrophil in the blood and neutropenia. In megaloblastic anemia also, in folate deficiency and vitamin B12, or in cases of the myelodysplastic syndrome, which will we pass already through this topics at the end of the lectures. Sometimes the neutropenia or the leukopenia, not due to only to the decrease or ineffective granulopoiesis or the production of the decrease the production or the ineffective of the production of the granulocyte from the bone marrow, but it is due to the accelerated in the removal or destruction of the neutrophils, which is most commonly seen in certain immunologically mediated injury, such as in the systemic lupus erythematosus, or sometimes in hypersplenism syndrome, in which there is a splenic sequestration of the blood element, as in the sequestration of the neutrophils, of the white blood cells, of the platelet, and phagocytosed by the splenic macrophages. Sometimes severe bacterial, rickettsial, fungal infection might lead to the neutropenia or destruction of the neutrophil. Drug also in the certain types of the anti-cancer drug or immunosuppressive therapy. Idiosyncratic reactions to certain drugs, not non-dose related. Maybe this is usually occurs in the patient which are not tolerate this type of the drugs, such as clomfenicol, sulfonamide, and chlorpromazine, thiouracil, and phenylbutazone. So this idiosyncratic reaction might lead to the destruction of neutrophil or accelerated removal. This was the last slide in the benign disorders of the white blood cells. Actually, in the next set of slides, we will proceed to the neoplastic proliferation of the white blood cell in the bone marrow, which lead to the leukemias. So we will go through the leukemia, all the types of the leukemia, and the symptoms of the leukemia, the molecular basis of the leukemia, the types of the leukemia, and then the types of the myeloid leukemias and the lymphoid leukemia. Thank you very much.